we did a randomized controlled trial for the electrocorticography recordings during epilepsy surgery. This is in itself already very special because this was the first trial in clinical neurophysiology and one of the first trials in epilepsy surgery. And it was a difficult trial to perform. What we intended to do was you have the normal pathway for a patient, so you have all the non-invasive recordings, the non-invasive diagnostics. The surgeon says, okay, I'm going to remove this and this area. There's a clinical reason why in our center we then also perform intra-operative electrocorticography. And then the question was, can we use the information from the high-frequency oscillations to better determine the extent of the resection? So either people were randomized for the group of spikes, so that's the sort of old method, so we look at interictal spikes, and the other half of the group was randomized for the high-frequency oscillations. And it were 78 patients in total, and it was a non-inferiority design, which means that we would like to prove superiority of the HFOs, but that would require a very large group. So then you need at least a multi-center trial. And to do that, you need to uniform your methods. And before you can do that, you have to at least be convincing that it's not doing worse and that it makes sense to do this. So that's why we performed first a non-inferiority design. So first we want to show that at least they're not doing worse than spikes. Unfortunately, the outcome was that the spikes seemed to be doing better. So that was not the outcome we were sort of hoping for. However, it's what it is. So the spikes were doing better. But then if we were looking at the data, and that was something we, of course, already noticed during the trial, if you have a patient for epilepsy surgery, beforehand, you can already say if you expect this patient to be seizure-free or not, like if the chance for seizure freedom is high. So in some patients it will be like 80 to 90%, and in some patients it will be below 50%. And what happened is that by accident, in the group of the HFOs, more people were randomized, which had an unfavorable pre-surgical pathology or pre-surgical knowledge of the pathology, let's put it that way. So if we correct for that, so if we correct the statistics for the fact that the groups were unbalanced, then actually the outcome is inconclusive. And if we split the outcome for temporal lobe epilepsy and non-extratemporal lobe epilepsy, then we find it's inconclusive for temporal lobe epilepsy. And maybe there's some hope for the HFOs in the extratemporal lobe epilepsy, in the sense that there we showed non-inferiority in this way. And I think it makes sense that is what we found, because I think that one big conclusion from this trial is that to determine if a patient needs an additional hippocampectomy, like we have a patient with temporal lobe epilepsy, and then often we perform electrocorticography to determine if the hippocampus needs to be removed as well. In that case, I don't think there's much predictive value in that. Why? Because the hippocampus also produces physiological events, and in people with epilepsy, almost what we see from our depth recordings, almost all patients show spikes in the hippocampus, and almost all patients also show HFOs on top of those spikes. So I don't think it makes sense to look at the HFOs in this particular group of patients. Still, I think, or I hope, and it's not just hope, it's also based on our future research where we perform, for instance, high density corticography, so with a lot of electrodes and with actually better machinery. We found out that some of the head boxes gave more noise than other head boxes. So I think if you improve the techniques, then still I believe that the HFOs can help you to define the epileptogenic zone. But that's still a belief, and we need further research to prove that.